Thank you so much for that lovely introduction. Before I thank everyone for allowing me to speak, I want to say you must be so tough to go through that interferon. That makes me happy that we've replaced that. I also want to recognize Dr. Halpern. Alan, while you were up, all of the dermatologists in LA called and wanted me to thank you for giving them more time to give Botox. Yeah. This is a very serious thing that we talk about today, the novel mechanisms and the novel therapies, because number one, the most important thing is we've made breakthroughs, but at one point, all of these breakthroughs have been a novel mechanism talk, a what's upcoming talk, a what's going on. And I remember presenting pembrolizumab for the first time and people not knowing what it was. So a lot of these things are up and coming and will become part of our armamentarium, and they're important. Also, it's great to be part of the group that responds and does well. In this audience, I have a very lovely ex-patient who I have known for 16 years, big-time survivor sitting somewhere out there, and that makes me feel good. But for the other 50%, we have to keep going, and that's part of what my practice is. Multiple clinical trials that are in phase 1 that look at any-line, many-line melanoma patients with the understanding that there's a little bit of arrogance about it, because what we have discovered in melanoma has become standard and codex for multiple other solid tumors. And while the melanoma cohort is a smaller cohort than lung cancer and breast cancer and some colon cancer and prostate and others, what we have discovered in our journey has helped all of those patients. So we push on with this wonderful session. Here are my disclosures, and you can see I'm very conflicted, but the more conflicted you are, the more even keel the discussion that you have. But this also points to the fact that we have lots of people here in the fight with us, and given the climate these days, we will require all of the pharmaceutical people who are here to double down on their investment in clinical trials and patient care. I would also like to disclose that I work with lots of people who have been funded through MRA, including Bin Zheng in our lab, and Zev Ranai, who's come over to be the head of translational at Cedars-Sinai. So I'm very grateful for that. Bin, who will be around here somewhere, also holds the Deborah Black Chair in Melanoma Research at Cedars-Sinai. So just to let you know how much the Black family has done. And this is where we are. G.B. Shaw said this, and we have gotten is what we wanted. We have gotten involvement, new drugs, new therapies, and there have become so many new tools in our armamentarium that we have to now understand how to use them appropriately and who to use them for. So this is what's happening today in my clinic. This is the Angeles Clinic waiting room. And when a patient comes looking for other options, what we do. Here is the aforementioned Hussein Taubi slide. But as we have come to these have all come through randomized trials that have shown efficacy and improvement, randomized between what is standard and what is available to you now. And they have all come through the same pathway. These randomized trials take two groups, give them a treatment, and versus the other, they compare the incidence and they compare the outcomes, and if one's better, we move forward. And we have had a excess of these coming forward now. So for a patient who's in the audience now, or a patient advocate who says, do we really have the time? Remember that anti-CTLA-4 took over a decade to come to clinic, but I have patients who have been on trials, and within the time that they have come off of the trial, the full trial, hundreds of patients have accrued, and that therapy has become standard. Also remember that our patients with metastatic or advanced melanoma we have moved the bar, and their survival is now years. So they have the time to benefit from these therapies. And in the adjuvant, just moving forward, we have come back to what is now vaccines, whether they are vaccines made of the patient's tumor or other vaccines. I'm just going to talk to you about this one. This is the Moderna trial. It's very near and dear to me. Why? Because Jeff Weber is the primary here. But also, it is a way to make a personalized vaccine out of your tumor. And it has shown benefits. Now, these are curves based on what's standard, the yellow, the Keytruda, pembrolizumab. What's not standard is the pembrolizumab plus this vaccine. What we found is that we could make this with great fidelity. Over 90% of patients got a vaccine that had all 34 neoantigens. Those are proteins that are uncommon in normal people and are indicative of the tumor itself. It also had distance metastases-free survival, not just that it recurs locally and you call the surgeon, mine is Mark Ferries, and he takes it out, but it comes in a place where you are now on the clock with metastatic disease. It can delay that, and it's my belief that that is an indicator of overall response and benefit. What is interesting here is that this is a paradigm of showing your body antigens. These are proteins specific for a tumor. And when you think about it, that's where neoadjuvant therapy has been thought to be better. Because the tumor is in place, your immune system can see that. Well, neoadjuvant therapy is for only bulky disease. This is a way to get that benefit for all patients. And why do I like it? This has also told us that we have some biomarkers that are up here that can help us to understand who does better or worse. And if you have circulating tumor DNA still in your body, you're going to do worse. And it has shown even it can help those poor prognostic patients. So it's time for a randomized trial. And guess what? Even though I'm accruing to the phase 2 trial, the early trial, the randomized trial of 1,200 patients has fully accrued. And we will know those results in a couple of years. But not just that it is now in the adjuvant. There is a metastatic first-line trial going forward to show how a vaccine that is individualized, bespoke for you, can help without toxicity. One of the greatest things we saw is not an increase in toxicity. And for when I think about this, I think that it can be then uploaded to any combination regimen, and we'll move forward. The adjuvant trial is completed, and neoadjuvant trials in multiple solid tumors are ongoing. There's a Moderna trial for many, many, many years that looked at it in neoadjuvant and adjuvant in pancreas. It's accruing in neoadjuvant, adjuvant in lung cancer, and in gastric cancer. And also, it is becoming part of a post-neoadjuvant paradigm in lung cancer and can be in melanoma. Guess what? If you get neoadjuvant therapy, that is before surgery, and you have a surgery, and you don't get a good response, you're not going to do as well. But if you still have that tissue, you can get a personalized vaccine and give it with the adjuvant and possibly do better. And that is a paradigm that's ongoing now in lung cancer. It makes sense, where they have very poor prognosis and we can see those benefits. I would be remiss to say that there is a trial I didn't put up here, and it's all about vaccine. It's a vaccination against two epitopes that are on tumors, PD-L1 and IDO. And that's an IO-BIO trial in first-line metastatic disease of just Keytruda versus Keytruda plus that vaccine. And in the early studies, they showed a higher rate of getting complete response in the metastatic setting and durability. And that trial has already accrued. And that trial will read out by mid this year. And that trial is another way of getting an off-the-shelf vaccination. And this is something that's ongoing. What about biomarkers? whether it's circulating tumor DNA or gene expression profiling, we are now using those to identify patients who are at higher and higher risk and moving some of these benefits earlier and earlier. The whole idea of having metastatic therapies that work is bringing it into the adjuvant setting so that you don't have to get interferon willy-nilly. You, if you get interferon, would know better that it's helping you versus not doing anything. And the whole time while I was growing up in medicine, that was a question that was never answered. Well, now with circulating tumor DNA and biomarkers, gene expression profiling, we can help. So there are trials ongoing, even looking at a risk profile and bringing on stage 1B and 2A earlier and earlier. These are stages where we don't have adjuvant therapy because we'd have to treat so many to benefit. But if you could pull out those people who are going to do worse, you may find that the therapy helps. This is Dr. Christian Blanc. If you wait around, you'll see him around, but he's the one responsible for NADINA. And if you come, you'll see Dr. Patel, who's responsible for SWOG 1801. And both of them have shown a relapse-free survival benefit by giving therapy before surgery. So this was already presented, but NADINA showed this. NADINA also showed that if you had a great response, a pathological complete response, the chances of you recurring were about were less than a couple percentage. And we are now moving to cut the amount of adjuvant therapy we're giving. I'm trying to understand why I put that there. Well, I put that there because it taught us that the imaging is not good. It taught us that your relapse-free survival is better if you have a great response, and you need to do something if you don't. But now we're looking at how to use other things such as imaging to help patients. And we have known for a long time if a PET scan gets negative, you're going to do better. And this was data that was presented from Melanoma Institute of Australia and AC Camargo in Brazil. And it showed that if you're PET positive, if your PET scan is negative at the end of neoadjuvant, you're going to do much better. And then now a randomized trial in the neoadjuvant is coming. Now, I know we wanted to talk about advanced disease, but this is helping us to help patients not get advanced disease, but also not have morbidity from therapy, cutting down immunotherapy and cutting down the need for further surgery. And this is a trial, depending on who tells you what it is, has different names. It's a SWOG trial that's coming through by Alex Vanakoy, who's at the Melanoma Institute of Australia. He's a surgeon. And Mark Ferries, who works with me, he's a surgeon. This is lovingly called MSLT3, but it is the need to do a full surgery after neoadjuvant therapy. And this is a trial that's upcoming, will help us. I did mention predictive modeling, and this slide should have been earlier, but this is a prognostic 7-marker immunohistochemistry assay that identifies poorer prognosis in earlier and earlier disease. And if you can look here, it's melanoma-specific survival in very early low-stage disease, and this is helping us with stage 1B, 2A. If you can see the conclusions, the second dot. And a lovely gentleman in Germany named Dirk Schandorf put together a trial that takes patients who are 1B or 2A and gives them this type of predictive modeling. If you're low risk, you just go into surveillance. If you're high risk, randomized trial of giving you immunotherapy versus nothing. And it's already accrued. So a lot of this stuff will be coming out in the next couple of years or this year. But I can see it expanding how we utilize and how we identify patients who come in with a very small melanoma, but a huge risk of recurrence. That's a randomized trial coming forward. I love giving a talk and just shouting out people who have made great contributions. This is Paulo Acierto's data that was presented at ASCO this year. It is relativity 48. Relativity 47, you'll remember, was LAG3-PD1. Relativity 48 is LAG3-PD1 and CTLA-4. And what was so amazing about this is that they kept this under wraps for so long that they could present 4-year survival data. And this is what they did. Although it is only 46 patients, the survival seen here at 4 years is about 20 points greater than what we see with anti-CTLA-4 and anti-PD-1. So why isn't this becoming standard? Well, it will, because randomized trials are coming, but there was concerns about toxicity going forward. And what the lovely and talented Jeff Weber identified, along with Stephen Hody from Dana-Farber Cancer Institute, was that you can find biomarkers for poor prognosis. IL-6 is an inflammatory marker in the blood. I don't have time to get into it. It has a lot to do with some of the side effects and toxicities we see. And those patients who have high IL-6 levels, that they do worse. That's the red line, basically. So is it time for a randomized trial? Yes. We looked at if you could give IL-6 inhibitors with anti-CTLA-4 and anti-PD-1, and this is Adi Diab's data from MD Anderson Cancer Center. Dr. Diab will be going to Abu Dhabi to head that cancer center shortly. But it showed that not only could you decrease the incidence of the grade 3 or 4 toxicities, but T-cell trafficking increased. And that's the scientific way of saying we got more immune cells into the tumor and possibly a better response. So this is an ongoing trial that was started by Jeff Weber, so you can see his fingerprints over everything, including me, of the triplet regimen along with an IL-6 inhibitor, and has now gone into a randomized cohort of about 60 to 80 patients. And we will accrue that soon and see if, one, it decreases toxicity, which we have established before in other trials, but if outcome also is improved. What else is coming? Well, maybe the things that are sitting on our desks that we utilize when the patients come in, and you say, well, you get LAG3-PD1 and you get CTLA-4-PD1. Maybe we need to fix those. Maybe those can be made better. Maybe those can be optimized. And there are head-to-head trials now looking at 2 different PD-1 LAG3 combinations, and this is data presented by Dr. Meredith McKean from Sarah Cannon Research Institute with the LAG3-PD1 from Regeneron. And interestingly, this is not just competitive, it's good for you and me because it pushes the envelope of understanding if we can improve. Then these LAG3s have been dosed at higher doses and possibly could be better. But there are 2 randomized trials ongoing right now worldwide, and will have accrued by end of year, hopefully. But we know these people that prognosis is worse, and we have now begun identifying those patients who need more earlier, those patients who don't respond to PD-1, the primary resistant population. And we have started to become more aggressive with them. Dr. Beta Warner talked about TIL therapy. And if you look at that data, the initial presentation, 80% of those people who went on to that trial had never had a response to anti-PD-1 therapy. And so we didn't make the mistakes that we had made before of continually pushing the anti-PD-1 button, and have now understood that those patients need to be studied in a different fashion. We have classified them through the Society of Immunotherapy of Cancer classifications, and understood that we need other options or other combinations, other ways of igniting the immune system. Work being done by another person who'll be walking around here who's at UCLA, Katie Campbell, looked at SWOG 1616, which were patients resistant to anti-PD-1 therapy who came on a trial of anti-CTLA-4 and anti-PD-1, and has started to understand an identifier for these patients who will never respond, who don't do well, looking at plasma cell CD4 T cell networks. And now being able to take some tissue and look at it under a microscope, look at it, can tell us who is not going to do well with just pushing those checkpoint inhibitor buttons. So a lot. Is it the end of anti-CTLA-4? Not really. Those of us who grew up working on the CTLA-4 studies understood that there's toxicity and that we could not dose it higher and higher and higher. I didn't put in a slide in there, but Paula Isierto presented data of a randomized trial of just single-agent ipilimumab at 10 versus 3 and found the long-term survivals of 10 milligrams to be better. But we don't use that dose because of toxicities. So we are now looking at other things. We are looking at how anti-CTLA-4 affects Tregs. Those are the T cells that are not good T cells. And what we have understood is that they have higher levels of anti-CTLA-4. There are antibody drug conjugates that decrease that. This is a drug that's in our clinic from Georgia Immune, which is led by an immuno-oncologist, Samir Khalif, who's at Georgetown. And this is a Treg inhibitor that is a targeted agent. And we're now looking if we can reignite immune system by giving this drug. There are anti-CTLA-4 antibody drug conjugates that target CTLA-4 not in a way to decrease its interaction with the immune cell and the tumor cell, but to decrease Tregs, because Tregs have the highest density of CTLA-4 expression. But this is a drug that I just represented over at AACR Immuno-Oncology. This is a CAB CTLA-4. It's conditionally active. But then the thing is that this is made in a way that it does not get activated in normal tissue. It needs the acidic environment of tumor. And when that happens, it is activated. And when it is not in that environment, it is not activated. So possibility of low toxicity. What's interesting and what we are still trying to figure out is, can we dose this in a better fashion? The easiest way to say this is that the green is the dosage of this drug, the 3071 drug. The first dose is given as a single agent. The second dose is given with nivolumab, Opdivo, at the full dose. And we are now giving patients on this phase 1/2 trial doses that are equivalent to 5 or 10 milligrams per kilogram of anti-CTLA-4 therapy along with full dose of anti-PD-1 therapy. So this is ongoing and have not seen excess toxicities there. It is hopefully going to come in a randomized trial, which is still being considered now, but on hold given some of the things that have happened. Since someone from Replimune identified and introduced me, it should be important to talk about what they are doing and how much they are all in on care. This is not something new, it is something better. We are all familiar with oncolytic therapies. That is virus injected into tumor, causing regression. In melanoma, few remember that there is an FDA approval in localized disease for that type of therapy. What happened was we didn't pay attention to metastatic disease and injecting everywhere and anywhere, which is what should have been done. Those other drugs took years to have the audacity to inject into viscera, liver, lung, and other. And we know patients with liver metastases that have lung cancer and melanoma do poorer, even if they have the same volume of tumor. Even if they're same everything else, you have liver mets, you do worse. So this is Carolina Robert's data. She presented at ESMO in Barcelona. And this is injection of a herpetic virus this is RP1. Please remember that RP1, because there's son of RP1 and grandson of RP1. We'll talk about that. But this is RP1 combined with nivolumab, anti-PD-1 therapy in patients who had failed PD-1 therapy, including lots of patients who have failed anti-CTLA-4 and anti-PD-1 therapy, and BRAF therapy, et cetera. And this is ridiculous to bring up to any audience, but this showed injecting into lesions caused reduction in other lesions. And if you can see the blue, so this is a plot that if it goes under the line, things are shrinking. So guess what? Things really shrink with this. That's one thing you get from the whole mishpuga here. But also, the red is non-injected lesions. So if you inject into something, other lesions around the body respond. And also, injected and non-injected lesions responding equally, and viscera, that is organ systems responding, not just skin and lymph nodes where we weren't really worried. Where other similar drugs failed, this is succeeding in very advanced melanoma. Here's an example of 2 patients, but you don't want that. You want to see efficacy. You want to see that it works. So this is all patients, 140 patients, not 40, not 60, but patients who failed the third, fourth over anti-PD-1 and anti-CTLA-4. 65 patients at 27% response rate. What about high stage 4? Not just the ones that have skin and other. That's the 1, 2, 3, 4, 5, 6th one over. 26% response rate. What about the primary resistance, the bad actors? That is the 7th one over. 36% response rate. And that's 92 patients. So that's great. But you want to see visuals. And so this is, the red is the injected lesion. The yellow is the non-injected. So responses in viscera, in liver, where we fail patients. And it's working. Good responses. It is now in a randomized trial. It's accruing at my clinic, and it's accruing at many clinics. And it's being randomized to very good second-line options, including LAG-3. So this is accruing. It requires expertise. But I told you to remember RP1. By the way, this is the trial, IGNITE-3, for those of you who want to go back. But remember, I told you, look at RP1, but also look at the other things that are there. If you go back and you look all the way to the right and down, the additional payloads. The payload in RP1 is just the GM-CSF, but we're adding an anti-CTLA-4 antibody in RP2. And that's amazing. Why? Because that goes directly to tumor that has a low lifespan. If you have toxicity with a virus, give an antiviral, and those die off, you can take care of toxicity. RP2 is being looked at in a randomized trial. I'll show you that in a second. But grandson of RP1, RP3 is coming. It has anti-CTLA-4, CD40, 41BB. So the future is also developing and delivering drugs that can be added for increased efficacy, whether it's starting off with a novel CTLA-4 that's better or not, or a vaccine, or a oncolytic. These are all tools that we can utilize together and can be tolerable. Here is RP2, and this was presented by Joe Sacco, and this is a lovely, lovely representation of a multitude of things. Look here. One over here. Look here. Okay? Just look here. The red is, again, the injected lesion. We are injecting into liver, and we are injecting and re-injecting and injecting again, and it is safe. And we are seeing responses in not just the red, but all of the yellow. These are non-injected lesions. These are places where we fail, and we have seen benefits. And guess what? There's a randomized trial coming. It's opening. It's for uveal melanoma. So great trial, and it's going into places where we need help. And this is the schema. You can look at it later. What else? Few people know that oncolytics are wonderful because they work locally, they have low toxicity, and they can help those patients that need a lot of help. And this is the other type of cutaneous malignancies that we don't talk about at MRA a lot. This is a lovely trial. It's ongoing near me at the University of California, San Diego, but other places near you. This is a phase 1b2 study of RP1 in solid organ and hematopoietic cell transplant patients. And again, you'll know that in solid organ, it is very tough to give these immunotherapies. And post-stem cell transplant, it's contraindicated to give PD-1 therapies. You'll remember that the data shows a 50% rejection rate if you give someone who's had a transplant a PD-1 inhibitor. But these things work in those patients and are tolerable, and these things are important, not just for melanoma patients, but squamous cell carcinoma is a major morbidity risk in patients who've had transplant or any type of long-term immunosuppression. So I'm just going to call that out. It's safe, and it has very few side effects. Let me transition into other T-cell therapies. I got time. And this is a breakthrough. I want you to think about T-cell therapies as just a way to get T-cells directly into the tumor, near the tumor. It is not just TIL. It is not just TCR-T. These are T-cells that have a targeting agent put into them. It is not just the ImmTACs that we'll talk about coming forward. It is anything that affects the T-cell. So what are we understanding here? This is a TCR-T where you get apheresed. You take the T-cells out of the patient. You put in something that targets it, makes it a heat-seeking missile to something expressed on the tumor. PRAME is expressed on melanoma 90% of the time. And this is early data that has been presented, but is now in a randomized second-line trial going forward at multiple institutions that has shown responses in, multiple types of cancer. This is cutaneous melanoma. Here is uveal melanoma. Uveal melanoma does express PRAME. It is in other solid tumors. PRAME is expressed in lung cancer. PRAME is expressed in ovarian cancer. PRAME is an important target, and this is looking at that in melanoma. Randomized trial coming forth. What else? I love this because a lot of you are familiar with this pathway, the ImmTACs, the immune mobilizing T-cell receptors against cancer, which is just a way of saying it is a double-sided plunger. One side targets the protein that is being expressed, PRAME. So a PRAME-expressing tumor cell shows part of that PRAME protein here. And the other side targets CD3, which is on T cells. And so this is a matchmaker. It brings the tumor to the T cells, says you guys got to get together, and causes T cell lysis and death. We have seen data that it works in tissue. When we give the drug at efficacious doses, you see an increase in gamma interferon, which is associated with PD-L1 expression. And you see the lymphocytes in peripheral blood going down. They're trafficking to the tumor. How do we know that? We have biopsies showing that. Here's initial data presented at ESMO now many years ago in responses in uveal melanoma, cutaneous melanoma, ovarian cancer, lung, and others. And now ongoing in combinations with other ImmTACs. Well, you're all familiar with that because that's tebentafusp, that's Kimmtrak, is the same platform targeting GP100. This is felt to be one that can target multiple solid tumors, including cutaneous melanoma. When you look at PRAME expression, you're giving them a better outcome. When you look at scans, the scans are not shrinking as much, but people are doing well. What we have understood is by looking at circulating tumor DNA and the reduction, these people that have 50% decrease, those are the people that do better regardless of what the scans are showing. So we're understanding novel therapies, novel ways to understand who's benefiting, to continue them so that we don't discontinue and they don't benefit. Oh, randomized trial. This is PRISM-MEL. This is taking patients who are HLA-A2 positive that can express PRAME, randomizing them in first line with the PRAME drug itself. It's called brenetafusp plus PD-1, that's the bottom, versus nivolumab or nivorella, which is Opdualag, first line. So a standard first line versus this combination in a subset of patients that can express PRAME. So a more focused trial. This is accruing right now and is doing well. But also Kimmtrak, we talked about that. We published data that this has response in HLA-A2 positive cutaneous melanoma, that is tolerable with PD-1 and CTLA-4. And this is a second-line trial for patients who have failed prior anti-PD-1, PD-L1. They have had to have had prior anti-CTLA-4 if they're BRAF mutated. So these are people that need therapies. It takes everything except uveal. So it takes acral, it takes mucosal, and it's looking at randomization between Kimmtrak, which is the ImmTAC targeting GP100, Kimmtrak plus an anti-PD-1 versus an investigator choice 1-to-1-to-1 randomization, and that's accruing. Well, let's figure out who does well on this so we don't put the wrong people on it. And for all T-cell therapies, there has been this idea that the more you have naive or stem cell-like T-cells, subgroup of T-cells, the better you do. And we have found that from this. This is showing that if you have that T-cell signature of more stem cell and naive, you do better with brenetafusp, and this was recently presented. But we are now looking at it. We are looking at it for many different things. So put a pin on that. What about TIL therapy? There's a randomized trial for that. First line TIL, like Dr. Betoff-Warner showed you, I need to speed up, versus PD-1. There are new modified TILs. We have a trial that has CRISPR'd out PD-1 from the TIL that's being given. And it's being looked at not just in melanoma, but in lung. This is the Obsidian drug, which is TIL that has a drug responsive domain. It has interleukin 15 in it that can be expressed by giving a pill of acetazolamide. So when you give this drug, you don't have to give interleukin-2 afterwards, so more tolerable. What has initially been shown and presented by Dr. Amaria from MD Anderson in 9 patients, a low number of patients, but a 20% complete response and a 100% clinical benefit. It is now accruing in trials. Why is this great? Well, in the trial, we're looking to decrease the amount of lymphodepletion. You'll remember Dr. Beto-Warner said that's very important. Very important. So decreased lymphodepletion. No surgery for this. They're getting TIL from just core biopsies of tumor. So what does that do? You don't have to do a surgery. Cost is less. Morbidity is less. Time to TIL is less. And no interleukin-2. Don't need to hospitalize. Cost is less, toxicity less, morbidity less. And because these cells remain in the body with memory, and they have a drug-responsive domain, if you see that the response is not becoming durable, you can give the acetazolamide again and pulse again and get those T cells going again. So that's accruing. There are novel drugs. I'm running out of time, but novel drugs here, such as this drug that was presented by Chris Wenzel, who's at the Angeles Clinic and Research Institute. Wow. But this is a checkpoint. But this is an NK cell checkpoint. We haven't even talked about NK cells, and that's coming. And in melanoma patients, we saw huge benefit, and this is going into combination with PD-1. Here's our cutaneous melanoma. It's always nice to show pictures that look very well, but this is a patient that benefited as a single agent. This is stuff from NKgen, and you can see great response. This is wow. But when you look down, this is not melanoma. This is chondrosarcoma, desmoplastic round cell sarcoma. These are tumors that don't respond well to immunotherapy, and we're seeing great responses looking at NK cells. T-cell receptor-based therapy with NK cells is also happening. This comes out of the lab of Katie Rezvani at MD Anderson. And what we're finding here is that we can get response in patients who have had no response to checkpoint. And we're looking at this now in solid tumors. And I didn't talk about brain mets because Dr. Beto-Warner talked about brain mets. But we haven't even gotten to the final frontier, which is leptomeningeal disease. So if we succeed, the place which is hardest to work is in the brain when it has gone to the covering of the brain. Poor prognosis patients where we have seen the ability to not only give checkpoint inhibitors, like anti-CTLA-4, anti-PD-1 work done by Bela Glitza, who'll be walking around here tomorrow, but also with CAR T therapies, also with TIL, and also with NK cells. So I think as I come to the end, I would say that it's not done. There's a lot more to do. And it's not all because of metastatic disease. It's for all solid tumors. The idea of the RP1 going and getting breakthrough designation and possibly being available for us by mid-year only gives us something else to work on the harder to treat patients. And it's a wonderful time to be trying to answer these questions. This is the Angeles Clinic in Cedars-Sinai. It's always good to present on the East Coast during the winter and say if you're ever in or you want a place to seek refuge, you're welcome. Thank you.